Welcome to this latest edition of the Langford Academy. Today's focus is on when to refer to a spinal emergency. My name's Richard, I'm one of the neurology specialists here at Langford Vets, and I'm joined by my colleague Dr. Gareth Jones, who's one of our first year neurology residents. So just as an overview of what we're going to cover today, we're going to have a chat through just the history and differential diagnoses, some revision on spinal neuroanatomy, and then we're going to have a bit of a chat through a few cases of the most common neurological emergencies. So we're going to start off with an ambulatory dachshund that progresses to paraplegia. We're going to have a chat about a monoplegic Labrador, a Shih Tzu with non-specific neck pain, and then delve into a bit of a discussion on how to manage a spinal fracture. And hopefully our aim at the end of this webinar is just to be able to generate a list of differential diagnosis from our neurological history, be able to localize the problem to a specific neuroanatomical region, and understand when to refer or when it's safe to monitor a case and treat it conservatively. So just an overview of some history taking. We usually like to start with just a little bit of general history, predominantly just focusing on any signs of systemic illness with the animal, so weight loss, coughing, sneezing, vomiting, diarrhea, any polyuria, polydipsia or polyphagias. If the owners are still in contact with any of the littermates or the breeder, and if they've had any significant medical surgical history. Travel history is also quite a big one, obviously with the development of brucella and the zoonotic potential for that. And then with regards to the neurological history, really the main important factors were when was the animal last normal, how quickly did these signs come on, i.e. whether peracute, acute or insidious, so like a chronic, slowly progressive disease, and how they've changed since the owners noticed them. Is it progressively getting worse? Is it static or is it slowly getting better? And once you've got the onset and the progression of the clinical signs, it's really easy then to sort of generate a list of differential diagnoses just based on your vitamin D or ANNPE acronym. And just to recap what these mean, so peracute means that the signs have come on over seconds to minutes, acute onset minutes to hours, subacute within sort of 24 to 48 hours, with chronic or insidious would be over 48. So these tend to be really slow in onset, and some owners might not be able to give you a specific time frame. And then regarding the progression, static, exactly the same, not getting better, not getting worse. Resolving, the animal's getting better, and progressive, the signs are worsening. So again, just going back to this graph, we can see then that diseases that tend to be acute onset and progressive would fit with the inflammatory infectious disease or neoplastic disease, and conversely, signs that are acute and resolving would fit with like a vascular or traumatic injury.
To the spinal cord, we break it up into four spinal cord segments. We have the two cervical spinal cord segments of C1, C5 and C6, T2, which, if they're affected, will affect all four limbs. And then we have the fracture lumbar and lumbar sacral spine segments of T3, L3, and then, broadly speaking, L4, S3, which can be further broken down. For the purpose of this talk, we're going to focus a little bit more on C1, C5 and T3, L3. So if we focus on C1, C5, we tend to see patients having issues affecting all four limbs. So they're either ambulatory tetraplegic or non-ambulatory tetraplegic, or in severe cases might be tetraplegic. But in some animals, we might just have neck pain or cervical hyperesthesia only. With a C1, C5 injury, we would expect that proprioception would be delayed or absent in all four limbs. We can have deficits in the thoracic limb spinal reflexes, particularly the withdrawal reflex, but you would expect that the pelvic limb reflexes such as the patellar reflex, the pelvic limb withdrawal reflex and the perineal reflexes should be intact. And you'd hope to have normal cranial nerves, with the exception you might have it anosognosia if there is a level of Horner's disease, because the sympathetic nerves fibers run down through the spinal cord and exit at the level of T1, T3. So here are just some videos of dogs with a C1, C5 myelopathy. So as you can see here on the video on the left, that the patient is needing support and has paresis in all four limbs, subjectively worse in the thoracic limbs compared to the pelvic limbs. And the second one, you can see a patient that appears to be, to a great extent, tetraplegic. You can't see any voluntary movement in any of the limbs, potentially a little bit in the left, and also a flaccid tail, and there's no movement there. When we come to T3-L3, we tend to see a size affecting only the back limbs or the pelvic limbs. So these patients, they can be just presented with back pain alone. They might have a level of paresis, so paraplegic in their pelvic limbs. They may be ambulatory, non-ambulatory, or in the worst situation, they might be paraplegic, so there's no voluntary movement in their pelvic limbs and or their tail. From a neurological exam point of view, we'd expect postural proprioception deficits just in the pelvic limbs. You'd have normal paw placement and hopping in the thoracic limbs. Spinal, you can get some spinal reflex deficits, mainly seen in the withdrawal reflex, although you'd hope that you'd have a normal patella and or peroneal reflex. The cutaneous trunci reflex could have a deficit, so you could have a cutoff, and that can sometimes suggest exactly where the lesion is. And they can be painful on thoracolumbar palpation. And the top tip there is just to gently hold the abdomen when you're palpating the spine, because sometimes you might not get an obvious vocalization, but you can feel them tensing up their abdomen. And in these cases, they should have normal thoracic limbs and have normal cranial nerves. So here are just some more gaits of some dogs that have a T3-L3 myelopathy. So on the left, we can see an ambulatory paraplegic patient. You can see they're quite weak when they're walking. They've got a level of severe ataxia, but the thoracic limbs are nice and strong. Again, in the middle, we've got a non-ambulatory paraplegic patient, a patient who's not able to take more than 10 steps unaided. And in the far right, we've got a patient who's got minimal movement in their pelvic limbs and is just using their thoracic limbs to pull them along.
So just a note on deep pain perception. This is a really important test to do on all animals that are presented with paraplegia to establish if they have intact nociception or not, so whether they're grade 4 or grade 5. It's one of the best prognostic indicators we've got for predicting recovery in these animals, so really important that it's done. What we recommend doing is applying pressure with a pair of forceps across the nail bed, and you want to do this on the medial and lateral digits of both pelvic limbs and on the tail base. And a conscious perception of pain is these animals turning and looking at you doing this, barking, yelping, crying, trying to bite you. And if they have conscious perception, we consider them to have intact deep pain or intact nociception. What isn't a deep pain response is just pulling the leg away, because that is just you stimulating the withdrawal reflex.
So the first case we're going to go through is a lovely 4-year-old female neutered Dachshund called Leah even, and her history is she acutely became painful after going downstairs. On her general clinical exam, it was unremarkable. Her neurological exam showed that she had a normal gait, but she was a little bit kyphotic in her lumbar spine, a little bit arched, and her cutaneous trunci cut off at the thoracolumbar junction with repeatable pain on palpation at this region. So using the information that Rich talked about earlier, we're just going to work through this case and make a plan of attack. So look at the onset and the progression, the pain, symmetry, neurolocalize it, give us some differentials, and then we can make the discussion as to do we have conservative management or does this case require urgent surgical management. So onset-wise for this case, we've got acute onset, we've got no progression, so it's not super helpful. This patient probably presented quite quickly. From a neurolocalization point of view, we've got kyphosis, we've got a thoracolumbar pain, we've got a cutaneous trunci cutoff at T13-L1. Not a lot to go on, but the cutaneous trunci cutoff would be indicative of a T3-L3 lesion. And given that this dog's basic differentials based on this dog's age, breed, and the history, I'd expect an intervertebral disc extrusion the most likely cause, although without further investigation we can't rule out a discus spondylitis or neoplasia. However, we'd hope to see some signs of concurrent disease such as weight loss, coughing and pyrexia, which aren't present in this case. So these cases have just back pain only. They can be quite interesting but challenging ones for us to know exactly what to do, because they don't always make great candidates for extensive testing, just because back pain alone can be very difficult to localize. And if there's no red flags of systemic or sinister disease, most of the time we'd expect these patients to get better with minimal intervention. So these cases, when we do conservative management, as we recommend this, the mainstay of this is sort of rest and the use of non-steroidal anti-inflammatories, as long as there's no contraindication for that. And the idea for rest is to try and minimize any high impact activities such as jumping, running, playing with toys. And what we want to do is we want to allow the annulus, which is the capsule around the soft part of the disc, to fibrose, so hopefully no more further disc material can extrude. because that means that these cases though can have a high risk of relapse. Sometimes you might have owners that are too worried to have the animal at home, and it's absolutely sensible if you want to admit these cases into your hospital for pain management and monitoring to see how the neurological signs change over a 24-hour period. You might, if you see signs of deterioration, that can allow you to escalate your plan and also allow you to escalate analgesia if needed. But hopefully if they're static or improving, then you can discharge them for further management at home or refer them if they are deteriorating. So the questions for, I guess, to think about is when do we refer, and what would we want to see to have these cases referred. So the first one would be progression of clinical signs. So if you accept that I had the dog and he was walking quite happily, but the next morning you're finding that it's non-ambulatory or in the worst case paraplegic, then that definitely would be a red flag to refer, because it's suggestive that there's ongoing spinal cord compression or contusion stopping the signals getting through. Patients that have really severe pain that aren't responding to multimodal analgesia, sometimes we find that pain alone can be quite debilitating in these patients, and despite rest and pain relief, they still have ongoing pain. In those cases, we could look to refer, particularly if there's opioid analgesia is not enough to stop it, or signs recur once the opioids have stopped. Signs of concurrent systemic disease are also a sign to refer, just because it might change the differential away from being a disc extrusion to another pathology that might need intervention. So if the patient's got persistent pyrexia, if you identify neutrophilia, if you identify signs suggestive of inflammation like a CRP, or there's systemic clinical exam findings such as enlarged lymph nodes, those are all reasons to make an urgent or emergent referral. However, we'd like to stress it's always happy to see have a case referred to us, even if it's ambulatory or just back pain alone. And it just depends on the severity and the time frame we'd need to see it in urgently. But any concerns, always happy to see a case in. So just to summarise with this case, unfortunately, this is how we managed the case. Initially managed with meloxicam, rest, and initially she showed some signs of improvement. And we spoke about the idea that pain resolved in the kyphosis. However, she managed to escape into the garden and chase the squirrel, and after that she then represented. Her clinical exam was still unremarkable. At this point, no, she was paraplegic. On her exam, she had loss of proprioceptive responses in her pelvic limbs, with intact spinal reflexes. She had deep pain positive all digits in her tail, and a cutaneous trunci cut off in the fractal lumbar junction, with again pain in this region. So again, using the same plan of attack, using the progression, onset, pain symmetry, neurolocalization, differential diagnoses, and then we can work out, do we continue conservative management or do we need to refer this urgently? So in this case, we know she's paraplegic with intact nociception. So using the rest of our clinical exam, we can rule out an obvious forebrain or brainstem lesion because the cranial nerves are fine, no change of mentation. She's a bright, well, happy dog. The thoracic limbs are fine, so we know it's unlikely to be C1, C5 or C6, T2. Therefore, the lesion must be either T3-L3 or L4-S3. So without more information, we'd localise this to T3-S3. Given the fact that we have some specific changes on her pelvic limbs, the fact that her pelvic limb spinal reflexes, such as patella, and her withdrawal reflexes are intact, and the fact that her cutaneous trunci cuts off at the fractal lumbar junction would make us want to localise this to a T3-L3 lesion. Just to recap this case, we've got a 4-year-old female named Daxi, who's initially had acute on spinal pain, which has now progressed to paraplegia. Her neurological exam localises to T3-L3. So the most likely differentials are either a degenerative disease, such as intervertebral disc disease based on her breed, or other diseases such as inflammatory diseases like a meningomyelitis of unknown origin or a neoplasia. In this case, based on the history of the sigament, the most suggestive lesion would be an intervertebral disc extrusion. But that's based on the fact that she improved with conservative management, then relapsed after high impact exercise. You wouldn't expect a neoplastic or infection inflammatory disease to develop with just rest or non-steroidal. We'd expect them to either static or continue to get worse. Now, what would you do in this case? So this is just to recap the information out there on the sort of prognosis for dogs who have a T3-L3 intervertebral disc extrusion. So as we can see at the top, those who just present with just pain have an excellent outcome with surgery, but also have quite a good outcome reported with medical management, so just rest and conservative management alone. As you can see, as the grade deteriorates to grade 2, to grade 3, to grade 4, to grade 5, the outcomes change. So in this situation, we have a grade 4, so we have a paraplegic dog, but it has intact nociception. So now we've got quite a difference in outcome between medical management at 60% and surgical management at 93%. So in these sort of cases, we would recommend surgical intervention. So while what we would do is we'd get you to manage pain relief while the patient's in your clinic. If you feel it needs pain relief, give it pain relief. It won't interfere with our neurological exam at a later date, and then definitely look to make an urgent or emergency referral in this case. What can be helpful is if the patient's not checked the patient's urination status, so you might need to express the bladder, particularly if it's a long journey to the referral centre, or if you have to keep the patient overnight because it can't be seen till the following morning, placing an indwelling catheter, either an in-out rigid catheter or Foley catheter. Just these patients have a T3-L3 myelopathy of lost movement in the back legs, are unlikely to be able to urinate by themselves, and particularly our brachycephalic friends, such as French bulldogs. Definitely you can give some mild sedation to help with transport, because we do see sometimes the Boas crisis, they can present in Boas crisis. And one thing we do recommend to all vets to advise owners before patients come to us is there is a risk in these patients they could have a severe Boas crisis and unfortunately die during transport. So this is just some CT images on the left that shows this sort of nice bright white spot within the vertebral canal here at the level which is causing compression of Lear's spinal cord. You can see in the transverse section how much of the canal is taken up by the disc extrusion, and in the nice intraoperative photo you can see there's a lovely area of disc material that's causing the spinal cord to be tented up. So this is the view for the hemilaminectomy site we see at the time of surgery. And now I'm going to hand over to Rich to talk about case 2.
Thank you. So case number 2 is a 2-year-old male entire Labrador called Zinzan. His history is a peracute onset yelp when he was off lead running chasing a ball, and the owner reports to you that he was completely paralysed, dragging himself on both of his back legs. By the time the owner had got him back to the car, driven him to yourself, it was reported to have improved and was now weight bearing on his right pelvic limb, but still not much movement on the left pelvic limb. So on clinical exam, he's a little bit overweight, but otherwise unremarkable. No red flags for systemic disease, so no signs of murmur, no signs of peripheral lymphadenopathy, and normal rectal temperature. On your neurological exam, you find that he's ambulatory paraparetic, but significantly worse than his left pelvic limb. He's got absent proprioception to the left pelvic limb, and it's delayed to his right. He's got intact spinal reflexes. You can't find any pain on spinal palpation, and his thoracic limbs and cranial nerves are normal. So, much like with the previous case, our plan of attack is initially work out from the owner the onset and progression. Is he painful? Is he worse on one side, or are both sides pretty symmetrical? Generate a list of differential diagnoses from the onset and progression, and work out, do we need to do conservative management or does he need referral? So this is just a video showing his gait. So you can see with the sling, he's able to make good movement on his right pelvic limb, but there's not much going on that left pelvic limb. It's just getting dragged beside him. But his thoracic limbs, they look quite normal. He's moving his head from side to side. He's looking through the doors. He looks quite bright and attentive. So going back to our onset and progression, from the reports from the owner is acute onset or peracute onset yelp, but it sounds like things are getting better over the time frame without any specific treatment. So just a recap of the neurological examination, much like we did with the last case. So with Zinzan, he's got absent proprioception to his left pelvic limb and delayed proprioception to the right pelvic limb with intact spinal reflexes. He's got a cutaneous trunky cutoff at the thoracolumbar junction, but no pain or spinal palpation. And much like the previous case, his cranial nerves are normal and his thoracic limbs are normal. So we're quite happy that the front end of the dog is normal. So we'd localise in T3 to S3. And if we want to be a bit more specific, we can localise him specifically to T3-L3 based on the fact that his spinal reflexes, his femoral and his sciatic nerve, which we test by the patellar reflex and the withdrawal reflex respectively, are both intact and both normal. Just to summarise this case again, we've got a peracute onset and resolving history, so he would fit into one of these two here, which would be traumatic or vascular. He localizes to T3-L3, and our top differentials for this dog is going to be like an ischemic myelopathy, which include things like fibrocartilaginous embolisms or an acute non-compressive nucleus pulposus extrusion. So the question that we've got now is, do we need to refer him or can we manage him conservatively? The first big differential is an ischemic myelopathy, and most people would just refer to these as fibrocartilaginous embolisms or FCEs, but there are quite a few other things that can cause an ischemic myelopathy, which essentially just means that the oxygen supply to the spinal cord has been obstructed for some reason, and things like lipid embolisms or verminous embolisms, neoplastic embolisms are all possible. So this is why it's quite important, again, just to have quite a thorough history, because if you've got an animal that's potentially not had any prophylactic worming treatment, and maybe it's got signs of bleeds elsewhere, you'd be thinking could have lungworm potentially. As it got signs of coughing and weight loss, then a distant neoplasm could also be a consideration for this case. The other big consideration is an acute non-compressive nucleus pulposus extrusion. So this is just where dogs jump or twist, and a supraphysiologic force on the disc essentially causes it to pop, and part of the nucleus shoots out upwards, and it hits the spinal cord and it bruises it, and then the jelly from the nucleus just disperses around the spinal cord, so it just causes contusion. It's kind of what we can see here is this sort of white area, just the spinal cord would just be the contusive injury just from the nucleus, which is the right bit just under the cursor here, is shot upwards and it's hit the spine. So does it matter which of these two diseases that he has? Does he have an ischemic myelopathy or an ANNPE? It's really difficult to differentiate between these based on the history. You would need advanced imaging, and even with an MRI sometimes it can be really challenging to differentiate between an ischemic myelopathy or an ANNPE. If these animals are getting better, you don't have to image them, you can just rest them. Does it really change the management for them? Possibly. These cases that have an ANNPE will still have a hole in the annulus, so there is a risk that more material could come out if they were to do some strenuous exercise or jump or twist or fall over the following few weeks, whereas with an ischemic myelopathy you wouldn't really have a hole in the disc, so they shouldn't be at risk of relapse. So from a management perspective, advanced imaging might change how much you rest the animal, but it's not something that you'd absolutely have to do. And if the animal was getting better, let's say he was paraplegic at the initial injury, and by the time you saw them, they were up and they were walking on all four legs, you certainly could just rest these, but again, it's absolutely fine to refer them for advanced imaging if needed. So again, do we need to refer these cases? As we said with the first case, referral is an appropriate option, and in any case would always be happy to see them. But again, it's not something that you would have to refer if the animal's getting better without specific treatment. The big red flags for me would be if the signs aren't improving. So from onset to presentation, the dog's static. So if he was running around, he yelped, he was paraplegic, and when you saw him, he was paraplegic, certainly would be worth imaging the dog just to rule out they've not got surgical disease. If the signs are progressive beyond 48 hours, this wouldn't fit with a contusive or an ischemic myelopathy. And if the animal's still really painful when you examine it, it doesn't always fit with an FCE or an ANNPE. They're not typically painful on examination. So if they're ticking any of these boxes, it certainly would be worth referring them.
So moving on to our next case is a 8-year-old Shih Tzu called Padme even, and she presented with a 3D history of not being quite right and a 24-hour history of a low head carriage and sort of spontaneously knuckling on her left thoracic limb. Her general clinical exam, again, was unremarkable. Her chest was unremarkable, no lymphadenopathy, no pyrexia, although you did notice that she has some grazes across both of the top of her pelvic limbs, and her nails have been quite scuffed and quite worn down. When we look at her neurologically, she was ambulatory tetraplegic with spontaneous knuckling on her left thoracic limbs. So what do I mean by that is that she's giving way and she's almost collapsed on that limb. Her postural reactions were delayed in all 4 limbs. Her spinal reflexes and cranial nerves were normal, but she has some reluctance for neck flexion and spontaneous episodic vocalization throughout the consult room, throughout the consult when she's walking around the room and through examination. So again, using the plan of attack, let's try and work out the onset and the progression of these signs, and use that to help us neurolocalize the condition, and then provide differential diagnoses. Then we have discussion: do we need to do conservative management versus referral for advanced imaging and/or surgical intervention? So, like the first case, we have acute onset signs. They started, and since they started, they have got worse. So we have an acute onset progressive lesion. Now we look, can we find any of the information in the neurological exam to help us neurolocalize it? So looking at her neurological exam, let's see if we can try and work out where the lesion is. So she's ambulatory tetraplegic, so affecting all four limbs, and that's also confirmed the fact that she has absent postural proprioception of thoracic limbs and is reduced in her pelvic limbs, but her cranial nerves and her spinal reflexes are needed to further narrow down to find where the lesion is. Using the information we have, we know that her cranial nerves are normal, making it less likely to be a forebrain brainstem lesion. Therefore, it's most likely the lesion is in her neck, in the cervical vertebrae, or it could be neuromuscular. The way we tell the difference is looking at the spinal reflexes and the limb tone. So in a neuromuscular case, you'd expect more tone in all four limbs and reduced spinal reflex in all four limbs. Earlier, we already know that Padme has normal thoracic and pelvic limb reflexes, had an increase in extensor tone, so her legs are quite rigid. So that would make us localize her clinical signs to C1, C5 spinal cord segments. So we've got the acute onset and the progression, so we know that we're probably dealing with either an infectious inflammatory or neoplastic disease or a degenerative disease. We can localize it to C1, C5 based on the neurological exam. So our top differentials would be, again, an intervertebral disc extrusion given her breed. We'd also have a myelitis, as an myelitis of unknown origin, and we couldn't rule out a neoplastic lesion. So the next question is, what do we do about this case? Do we consider conservative management or do we refer her? So for cases that have just pain, so not Padme in this situation because she has neurological deficits, you can manage these with just analgesia and conservative management alone. And these cases, we definitely recommend multimodal analgesia, a mixture of non-steroidal as long as they're not contraindicated. Paracetamol and gabapentin can be really helpful. There is a risk of relapse. However, with time and pain relief, we'd expect in a good proportion of these cases just pain, and they will just get better over a 3 to 4 week period. However, in some dogs, we still recommend surgery if they have pain that is not well managed with multimodal analgesia, or if they start developing pain with deficits, as in this case, surgery is indicated. Depending where the disc is, we normally do what we call ventral slot, which is where we approach the neck ventrally and remove disc material. And these dogs have an excellent outcome with surgery. With normally these dogs coming in really painful, are willing to move, and then going home 40 hours later, almost back to normal. And here we can see in the MRI images, this sort of like a dark area is where the disc material has popped out from the disc and is compressing the spinal cord, and that's what's causing a mixture of the neurological signs and also the pain with the compression of the meninges. And again, it can be seen here. You can see there's a sort of irregular dark area, hyperintense region within the spinal canal, which is causing compression of the spinal cord.
Our next case is Frank. He's a 5-year-old male entire Pomeranian that was seen to be kicked by a horse on the owner's yard a few hours prior to presentation. On your general physical examination, you notice he's got extensive bruising already over the thoracolumbar junctions and tailbase and down his leg. He's got quite a marked increased respiratory rate and increased effort. When you auscultate his thorax, you notice that he's got reduced lung sounds to his ventral thorax, and he's also got palpable crepitus around his pelvis and to his thoracolumbar junction. So based off of this, you're quite concerned that he's got some severe orthopedic and potential spinal injuries. So we perform a very limited neurological exam. We don't want to get him up and walk him around just due to the concern for a fracture based on the history of trauma. But what we do want to do is just check that he's got nociception to his pelvic limb and tails, which he does. And you can also check for a cutaneous trunky cutoff, which you noticed is around the L2-L3 region. So this would constitute a neurological emergency, as we've got a real high index of suspicion for a spinal fracture, orthopedic injuries due to the crepitus around the pelvis. And we're also worried that he's also got issues with his lungs, like a pneumothorax, potentially with the dull sounds ventrally. So we've got a real high index of suspicion for a spinal fracture or luxation with Frank, given his history of trauma, and these are almost always due to a severe external blunt force trauma, such as an RTA or kick from a farm animal, falls off of cliffs, or gunshot injuries. We've seen that in cats. And any animal with neurological signs following trauma has a fracture or subluxation on something, and otherwise, and it's really imperative that these animals are secured to a rigid board or a splint of some description to prevent movement. They'll almost certainly have other soft tissue or orthopedic injuries, so pneumothorax, diaphragmatic rupture, bladder rupture, heme abdomen, and these are usually more life-threatening than the spinal fracture itself. So don't forget to do your ABC approach with these animals, assessing the airway, the breathing, the circulation.
So any case with respect to spinal fracture, in our initial assessment and stabilisation, one of the key things is to consider is appropriate analgesia, because these patients are almost certainly going to have a level of pain. We tend to use opioid analgesia, something like methadone. We tend to avoid non-steroidals just because until we've established their hydration state, their bulimic state, if you don't want to cause or potentially any further injuries and cause any sort of kidney injuries, given it's doing what they shouldn't do. Most of these cases probably will need some level of fluid therapy because they'll have a level of hypervolemic shock. So using appropriate crystalloid fluids can be definitely recommended. We tend to recommend collecting a minimum database, so looking at PCB total solids, looking at blood glucose, looking at lactate, performing a venous blood gas if you can, looking at pulse oximetry, that could be really helpful. Also measuring blood pressure, trying to establish if the patient is hypertensive or normotensive or sometimes hypertensive. These cases, particularly if they have polytrauma, might have a level of lung disease, so definitely oxygen supplementation is always recommended. Better to give it and not need it than not give it when it is needed. And then doing a level of sort of point of care or bedside imaging can be helpful, and that's where the sort of POCUS, the point of care ultrasound scan, can be really helpful. Can you look for signs of B lines, so signs of a lung injury, looking for like fluid in lungs, bleeding, etc. Looking for signs of free fluid around the lungs, so pleural effusion, pericardial effusion. Looking in the abdomen, is there evidence of the bladder being ruptured, the evidence of fluid in the abdomen, such as the hemoabdomen, is there evidence of a uroabdomen, etc. And also you can use the ultrasound to see is there potential evidence of a traumatic herniation with sort of abdominal organs sitting within the thoracic cavity. And on the right, you can just see here is evidence of some stuff you can find in these patients where they have polytrauma. So this patient here has a hemoabdomen where you've just sampled it. You see there's a large amount of hemorrhagic fluid in the abdomen.
As Gareth pointed out, the picture on the right is an abdominal centesis sample which shows blood. And in these cases, what's really important is to spin it down and compare that to the PCV of a central sample. And if the PCV of the abdominal fluid and the central sample are similar, you'd have a high suspicion of an abdominal hemorrhage. If it's clear to pale yellow, is it urine? And ideally, you want to compare the abdominal fluid creatinine to that of blood creatinine, just in case you suspect that you've got a bladder rupture and you've got urine free in the abdomen. Cases that you suspect have had a trauma and you suspect have got a spinal fracture of some description, as I said earlier, it's really important that these are immobilised prior to any further investigations to prevent them moving and to prevent any instability causing deterioration of the spinal cord injury. One way that you can do this is to secure the animal to a backboard, but if you haven't got that, an alternative is like we've got in this photo here, is you can just put some cardboard around the back and vet wrap it tightly to the animal. And I would recommend doing this immediately on presentation until you've excluded to the best of your abilities that these animals don't have a spinal fracture or instability. So after you've stabilised them, after you've given them oxygen therapy, fluid therapy, analgesia, etc., what you can do is take some radiographs, and we recommend lateral radiographs of the entire vertebral column. In the previous slide, we pointed out that up to 10% can have multiple fractures. So if you've got a dog that's off its back legs, it might have a fracture in its cervical region that might not be contributing to all of its clinical signs, but you definitely wouldn't want to miss. In an ideal world, you'd want to do orthogonal views, but only really recommend performing dorsal ventral radiographs if you can move the X-ray head to perform the horizontal beam radiographs. So what this slide is showing is the lateral radiographs on the left. So you've got the dog lying in lateral recumbency, you've got the X-ray beam head above the dog here. It's positioned on the table and you have the dog in a backboard or a splint to prevent movement. What you're seeing on the right is the horizontal beam X-ray that I mentioned earlier, where you can actually move the X-ray beam head down to the side of the animal and still take a dorsal ventral radiograph, but without having to move the animal. So the sensitivity of radiographs to vertebral fractures and luxations is about 72 and 77% respectively. So it's not a great test to completely rule out that there's not a fracture or a subluxation. And this top right radiograph is a really good one just to highlight that. There's a really subtle subluxation about L2, L3, which you could only really see if you scrutinise the articular facets really, really closely. But what it does show is the concurrent soft tissue and orthopaedic injuries really nicely. So we've got the sacroiliac injury here, we've got evidence of a prepubic tendon rupture, and we've got evidence of a diaphragmatic rupture with viscera in the thorax. So what I would say with these cases is, whilst you do see there's lots of other injuries, if you still suspect from the history and from your examination there's a fracture or subluxation, just treat the animal as if it has one until proven otherwise with advanced imaging such as a CT. The bottom radiograph does show quite nicely that there's a 12-13 subluxation in the cat. Also highlights the evidence of a pneumothorax in this animal as well.
When we look at spinal fracture prognosis, the most useful neurological finding we can have is the presence or absence of deep pain. So if deep pain is absent to all digits and the tail, reported the prognosis is hopeless, with a less than 5% chance of recovery with stabilisation. It's highly suggestive when deep pain has been lost that there's been a transection of the spinal cord from the injury, and in these cases, if you're confident you have no deep pain and you're confident the spinal fracture is present or subluxation, we would recommend euthanasia. However, if deep pain perception is positive, then the prognosis to recovery is excellent. These cases will need emergency referral for stabilisation, and the idea of stabilisation is to stop progressive disease. So the idea is to stop any worse damage of the spinal cord injury from more movement, etc. And also these cases probably also benefit from other stabilisation from the multiple pathologies they might have, so as shown in the X-rays in the last, the radiographs in the last two slides ago. Yeah.
So if you have an animal that you highly suspect has had a traumatic injury to its vertebral column and it has radiographic evidence of a fracture or subluxation, you've tested its nociception and it's got deep pain, we suspect it's got an excellent prognosis. These really need stabilisation, as Gareth just said, to prevent deterioration. If these animals are left sort of free range or to wander around either in the practice or at the back of the car, the likelihood that the instability in the vertebral canal could sever the spinal cord in transit is really quite high. So these animals really do need to be transported in a very safe and particular way to a referral centre for stabilisation. In an ideal world, what we would want is for them to be sedated and strapped to a rigid board, as I said earlier on, something like this, with a cardboard box wrapped around the animal and tightly secured in place with some vet wrap is the next best thing to try and prevent movement. And these are certainly useful if you can't get the animal to a referral centre on the same day. You need to hospitalise it overnight. You can place it on fluids, place an indwelling catheter and sedate the animal to stop movement. Or if you are transporting it at the same day to the referral centre, this sort of setup, sedating the animal to stop it moving in the car, would be what we would recommend. So in summary, essentially, the key aspects are that the onset and progression are really important to establish your differential diagnoses. If they're able to walk and there's no red flags with systemic disease, or the animals are getting better without specific treatments, they've not had things like steroids, they've not had antibiotics, they've just had pain relief and rest and they're getting better, then conservative management is absolutely appropriate. The cases that we would say would need referral would be those that have progressive pain or progressive signs of myelopathy despite rest and multimodal analgesia, or ones that have got concurrent signs of systemic abnormalities, so the pyrexias, the neutrophilias, or the lymphadenopathies, definitely good candidates for referral. The spinal fractures and the spinal subluxations would be the big emergencies that, if finances don't preclude it, would recommend immediate referral for assessment and stabilisation. I think the big take home is, irrespective, we're always happy to see cases and it's always appropriate to refer a case. And I think that concludes our webinar on emergency spinal cases. Thank you very much for watching.